You're listening to The Dental Guys, episode 42. Do your canals smell? A guide to endodontic diagnosis. The dreaded root canal. Is this something you love or hate? John and Wes know that success in endodontics starts with proper diagnosis. Are you doing root canals before you even know why you're doing it? Do you need endo ice, perio probes, and tooth sleuths? And most controversially, should you be doing root canals without a dental cone beam machine? Hey, we cut through into this chamber real fast this week on The Dental Guys.
Welcome to this week's episode of The Dental Guys. I'm John, the Dental Guy.
And I'm Wes, the Dental Guy.
And we are, it's hard to believe, Wes, 42 episodes in now. 42 episodes in. I mean, we've been really rocking and rolling. And this is an episode, because I just want to get right into this. I mean, this is an episode that it's a big deal. And I just have to hold back on like going too far. And I just want to say we're going to do an endo episode today.
Oh, man.
I'm pretty excited about it, but, you know, because we've been talking about endo.
Root canals.
Yeah, we've been talking about doing an episode on this because it's such a gigantic topic. To be honest with you, we don't really know how much we'll get through. Yeah, we got this like huge outline, and we're going to try to get through a lot, but...
Some interesting things, though. I mean, like...
Yes.
Just some interesting statistics, things like that. Really, we're going to hone in on a lot of different things, from everything from, you know, diagnosing properly all the way through what materials we're using and kind of get cut through the muck and
right. And just like we try to keep the show, we want to try to keep it a clinical show, and that's what you guys have kind of asked for.
Well, that's why we're here, right, John?
Yeah.
Take our clinical stuff to the next level, but
speaking of clinical, right, we're about to take it to the next level.
So, you know, John, again, here we are. Again. We're getting ready to spend some money.
Yes.
And it's well worth it. Listen.
Oh, yes.
We are going next month, and maybe I guess you're going to be listening to this here in a few weeks, and next month, the month of June, we're going to be traveling to Scottsdale, Arizona. Spear Education.
But we're back.
We're coming back, and we're coming back in a big way. And this time we're diving into sleep medicine, and you know, I know so many people are like talking about sleep and you know, we listen to so many people say if you're treating temporomandibular disorder and you're not treating sleep, then you're missing out on some of these cases.
Yeah, or even wear cases.
That's
right.
You're
putting veneers on people. Probably need to understand why they could break everything you put in their mouth if you don't understand sleep. And that really challenged us last year when we took occlusion. They're like, so first thing I do after like saying hello to the patient pretty much is talk about sleep.
Yeah.
On these wear cases, because they're like, if you don't respect that, the whole case could go down in flames. And so it was like Wes and I looked at each other. We're like, well, we don't know enough about that. We don't feel like we really know enough.
Man, T-Bone said, hey, if you're treating TMD, you better be treating sleep.
Mm-hmm.
You know, because a lot of your patients that have TMD problems have sleep issues.
Yeah.
And I think it's just, you know, not that every dentist is going to be treating sleep from a standpoint of diagnosing the sleep issue and referring and all that, but just being able to identify that there is a sleep problem.
Right. Just understanding it.
In children alone.
Oh, man.
It could be life-altering, not to mention in adults.
Yeah, we were at last year. I told Wes about this. I was at the Hinman last year, and I heard Jameson Spencer talk about kids, and he talked about, and it just blew my mind because he connected the dots. Man. He goes, so a lot of kids who have apnea because we're not doing as many tonsillectomies and adenoidectomies these days because they don't get reimbursed, and so the ENTs aren't doing them, and they're high-risk procedures. So that plus childhood obesity is leading to a higher risk of apnea, which those kids are acting out in school because they're not sleeping well, because that's what kids do when they don't sleep well. They get labeled ADHD. We give them Ritalin, which now they don't sleep as well because they're super hyper focused, And these kids can be like literally put into a category for the rest of their life that they are abnormal. Oh, now he's not saying every kid by any means, but it really opened my eyes to like, my goodness, like this could be a big deal for some of these patients. And he's like, so if you see a kid that snores and mom says that he's not doing well in school, it's sleep apnea until proven otherwise.
Wow.
I was like, oh boy, I need to understand
How
this
about
better.
this one? When they get up on the podium and Kevin Quishan says anterior wear without posterior wear is sleep apnea unless proven otherwise.
Yeah, man. It's challenging.
I mean, it's challenging because we're treating these cases, these wear cases, and I want my stuff to last.
Mm-hmm.
And the thing about spear education is, when you go there, you're gonna get it right.
Yeah.
And so we're super, super stoked about this. And not only are we going to learn a lot, but after we take this course, John and I discussed about learning the medical billing side of this as well. If it fits into our practice after we take the spear course, and we're going to implement it properly, we'll get our team involved, and as we have with any other thing. But you know what's great about spear education is that we're going to go out there. The dental guys is going out there, not just John and Wes, but we're taking the dental guys. And not only the dental guys are going, but Brad, the dental lab guy, is going to the sleep course.
Yep.
And
that's going to be great.
That's going to be really great because here's a Brad who has a device that he has been making, but he's not satisfied with it in his laboratory, and he just wants to take it to the next level. Mm-hmm. So we're super stoked about him going. But John, we asked for another interview, and they're giving it to us, and we're not going to reveal who it is. But until that time,
right. But if you've been out there to take seminars, you'll recognize the name, and it's somebody that's teaching one of their major seminars out there now, the big ones where they've got 200 or 300 people there, and we're gonna get to sit down after
mano y mano
and just and really find out where they're at on the topic that he teaches, which is a topic that Wes and I feel like we know some stuff about, and in a good way, but we know, you can always learn, and we're really excited to hear where Spear is going with this topic. So stay tuned for that. We'll give you more info after we get back and we kind of get that rolling and make sure that it is what we want it to be, and make sure that it's quality for you guys out there. Mm-hmm. But let's get to today. Today is one of those, like I said at the beginning, we've been talking about this probably since we began the show, Wes, is like we one day need to do endo. And we would always say...
Why do we keep putting it off? Because we both do a lot of root canals.
Yes, but we would always say it's so much. It's so much. Like we have both taken... we talk a lot about implants. We talk a lot about these...
Should we talk a little bit about our endo journeys, though?
I think it's a good start because it helps to understand why it's so... kind of daunting to put all this together, because we've both taken a lot of CE to get there. Wes, just kind of go through where you got to how you're doing endo now, and I'll do the same.
Well, so in residency, we were treating, patients, and as we felt the need to do root canals, it was up to us to choose whether to treat the case or refer it. And during that time, I was diving in and treating most molars at the time, with the help of a chief resident who was interested in going on beyond residency, and he became an endodontist. Actually, his dad was an endodontist. And so it was cool because we referred a lot to him. But we also referred to a local specialist who actually taught in our residency. And so I learned a lot of the way that I did, root canal therapy from endodontist in the town that the residency was in, and learned some great things from the attending clinicians there. But I tell you what, as I got about a year and a half into practicing, and I said, I'm done doing molar endo. For the reason why is I was frustrated. I wasn't finding a consistent result. I was spending too much time. It wasn't efficient for me. I just didn't have the tools that I needed, the knowledge that I needed to really treat it well. Okay. Yeah. And so a buddy and I decided to dive in and we started off with Dr. Buchanan's course. We found a course where there was a seminar where you sat in a lecture for a day, and then the next day you were hands-on with him. You had to bring mounted molars, you had to access, he had microscopes there available for us to use, and then we actually, it was a pretty small group, like 10-to-1 ratio with Steve Buchanan.
Nice.
And then later on, after that course, I decided, well, let's just take one of his arch nemesis course, Ruddle. And you got to take them both to understand them both and to appreciate the science behind what they do, because both of them are excellent endodontists. And I came out of that, ever since then, I came out of that just feeling confident about my root canals. Now, I'm not a specialist, and I don't treat special cases. I don't do retreats or anything like that, but I feel like that the endodontics that I'm providing my patients is up to snuff with modern techniques because of what I learned during those years treating or learning under Dr. Buchanan and Dr. Ruddle. John, what did you do?
When I was in dental school, we really didn't we got a really good scientific background on endo. We had a couple people there that really were kind of famous in the bacteria endo world who did a lot of research there. So we learned a lot about how difficult it was to do good endo from a sterilization standpoint, and a lot about the controversies, but we didn't really get necessarily a lot of clinical experience. And my dad, who I practiced with for a little while when I got out of dental school, my dad was very, very good at endo. And he had a very interesting, he told me when I got into endodontics, he said, you really need to pay attention here because, especially in a smaller town, I mean, in any town, but in a smaller town, if you can do good endodontics, where you don't have specialists necessarily in every corner, that is a real practice builder because patients are out of pain, and it's also a good low overhead procedure with profitability, and it's just overall a great thing to know how to do well. And he had an interesting story because my dad would practice right down the road basically from Cliff Ruddle and Steve Buchanan. And when my dad was a new dentist, Cliff Ruddle was a new dentist. And Cliff came down to my dad's little study club in Southern California and started showing slides back in like the 80s, like the late 80s and the early 90s. And he just started showing this stuff. Hey, this is what I'm doing. And it was really very, very new at the time. And my dad got to have a little bit of a relationship with him. And so when I finished school and kind of got out and took some lecture, we went out to Ruddle's hands-on course, which he did for years out in California. And it was a 3-day course, pretty much a day of lecture and then 2 days where you're just there with him. And he's pretty much there. You watch what he does. Majority of the time you watch what he does. And then he also watches what you do, and you get to treat some cases. And that was really the foundation of what I do today. I still use a lot of the things that I learned from him. And then also from Buchanan, like you say, those are the two guys that keep coming up. There are other good guys, and unfortunately those guys are getting up in age now, and one day, won't be doing it. Ruddle's not doing his hands-on course anymore, but that was definitely two of the people that I learned a lot from. And I think that early in my career, I spent a lot more time on endo CE than I did almost anything else for my first couple of years. Part of that was because my dad was so passionate about making me good at it, trying to get me up to his level. And I am so thankful for that because I learned a lot over that time. And I think that what that's brought Wes and I to is we both have a lot of the same kind of background on the clinical side of endo, the clinical side of how to treat. But this discussion today is really we're not starting there. We're not starting on treatment. We want to start where you would normally start. We want to try to make these next couple of shows with endodontics about where would you start with a patient when they walk in and they may need a root canal, and it starts with diagnosis.
Well,
right?
when
That's
you
the
see,
first thing.
John, the typical phone call is, hey, I've got a toothache. That's the classic phone call to a dentist office, and you work these patients in because they're in pain, especially if they're your patients. So John, a patient calls your office and your team puts them in the chair. You're over here in one room, and you've got your second assistant comes in and says, hey, Miss Mary, she's got a toothache, and, it's tooth number, she keeps pointing to the lower left, and it's, she can't really tell which one it is, but she says the lower left, and she's got a little pump knot on her jaw. This is the classic, hey, I'm coming to the dentist for a toothache, an abscess. And I feel like that we as dentists have some ways forgot there's an art to diagnosis. There's a little bit of knowledge that's required. But I want to first just give a shout out to the American Academy of Endodontics. John, in the show prep of this, you and I both, we both visited the AAE's website. And if you haven't been there in a while, you need to go there.
Yeah.
But their treatment guidelines are up to date.
Yeah.
They're free for general dentists, and they're free for anybody, really, for that matter. And you can go and download a slew of diagnostic guidelines and consensus statements that will help you formulate, hey, what's going on with Miss Mary and how to truly diagnose. So, John, let's dive into this and let's talk a little bit about some diagnostic guidelines.
Yeah, and let's split it up into clinical and radiographic. Because we really want to try with this show again to be as specific as we can. And I think that the first thing that we have to decide is, how do we attack a tooth or find out what the problem is? Is it a tooth? Is it not a tooth? How do we go through some of our typical diagnostics? And we have to just give a brief mention to the fact that we know that you're not going to be able to learn how to do this just from listening to this show. But we want you to at least go through, how would I do this in my practice and what is it based on? So, the typical patient, we walk into a room, they say, I've got pain in, say, the lower left part of the mouth. Let's just pick on the lower left. And let's say there's pain on this side. And then you can branch out into all these different areas. Is it temperature? You're going to ask the patient a series of questions. Is it temperature? Is it pressure? Tell me when it began. How long has it been going on? You want to get as much history from this patient. When was your last dentistry that was done? Was something done recently? What has changed? Do you wear a night guard? Do you have a history of sleep apnea? All these things that,
I'll interrupt here and just say, these are all questions that we train our assistants to ask.
Right.
And in some respects, a lot of these questions, simple questions, have been asked on the phone,
right,
to give that assistant a leg up. So the communication begins to kind of form.
Right. Hopefully, like at the morning huddle, a lot of these questions are already answered. Patients called, you've already got, which area of the mouth and some of the sensitivities that the patient reports. And you're basically, like you say, the assistant is confirming these things and then going through testing. And, after we've asked a lot of questions and we've gotten that history about, tell me when, tell me how, tell me how long, tell me what makes it worse, tell me what makes it better, a good dental history is obtained. Then we start going down the road of testing. And a lot of times for me, I don't take a lot of radiographs until we do some clinical tests, because I think we can easily jump the gun.
I agree.
And so I think one good thing to maybe go through is, I'll go through how kind of my clinical testing protocol, you go through some of yours, if it's different. Typically for me, we're going to go through percussion testing. We're going to go through bite testing with a tooth sleuth or a cotton-tipped applicator, the wooden part, something along those lines. We're also going to probe always the areas. We're going to do thermal testing, which for me is typically endo ice. And we're also going to look, of course, visually at the teeth and look at the size of restorations, look for fracture lines, look for obvious signs of swelling. We're going to also do palpation. We're going to palpate the buccal and lingual vestibules. We're going to feel for what we can feel, and we're going to press, and we're going to ask for responses on those things. And we may also do a joint and muscle exam if we think that this patient may, if they report upper and lower teeth, both in the same side or maybe both sides. We may even do sinus percussion if we think that there's a possibility there. So a lot of times, depending on how far the patient's symptoms take us, We may do all of those tests. We may do some of those tests. It depends on how quickly we arrive at a tooth.
Yeah, I think sometimes you walk in a room and you know exactly where the problem's at.
Yeah.
And sometimes you walk in the room and you don't know where the problem's at. So do we get out the endo ice every single visit? No. Why would you do that?
Right.
You know, because sometimes it's obvious that if you're doing your percussion test, you know, on your initial clinical before you maybe take a radiograph or something like that, or your assistant comes in and she's like, hey, look, I did a, you know, baseline percussion test on the opposite arch and I went over and patient is like definitely hot on tooth 19. And you're like, why don't you go ahead and get an x-ray of that? And then the x-ray pops up. It's a single x-ray, periapical, and it's like, boom, there's the abscess. Now, why would you go in there and stick endo ice on the tooth, you know, and just cause the patient more harm? I mean, that to me is ridiculous. I mean, I have a problem with that. I mean, like, would you do that, John? I mean, if it was obvious?
Not in that scenario. Not in that scenario.
Not in that scenario.
I think that if you go through, you know, I think that
if you ask the patient if it's a cold sensitive and like you take your air water syringe tip and you just kind of isolate the two teeth surrounding it with a cotton roll, and take your cotton rolls and just kind of hold it on the adjacent teeth. Just spray a little air at the gum line. They'll go, oh, that's it right there, you know? And you come one tooth forward or one tooth behind. You know, the question gets in here is like you're really, you can give a kind of a differential pulpal diagnosis right at first. You can give a definitive pulpal diagnosis once you actually do the root canal. Intraoperatively, make sure you're writing both down, kind of a differential right at the beginning in your note, and then when you get into the root canal, when you pulp the chamber and you see, you know, that this is definitely a irreversible pulpitis or necrosis, then that's your definite diagnosis. I
think that the problem that I see that many people don't do enough though is to, I mean, because here's where you can really mess up is when you assume that it is a single tooth, you know, without doing enough testing. And so I think that, you know, if your assistant is doing all your testing for you and you're not asking questions like, does it hurt upper or lower or both? On some of these tests, you know, I've definitely seen so many, and I think thermal testing, oftentimes I agree with what you're saying about not subjecting the patient to more thermal testing than is necessary. Completely agree. But I definitely think that if there's one test that dentists are the most unlikely to want to do, it's endo ice, because it does hurt the patient. But I love it. And I don't mean I love hurting the patient, but dude, I want to know. I want to know. You know? Is it irreversible or reversible?
Let me just say this:
where I'm at.
If you've never used endo ice, I mean, and really dive into it, it is almost definite. It is almost definite to me whether a tooth has a problem or not. I mean, it really, really used properly, when you isolate the tissues and their surrounding tooth structure and based on the tooth you're going for, it really does work. First, remember, establish a baseline. Go to the opposite, you know,
the contralateral side.
Contralateral side. Do some tests on multiple teeth. Give that patient a baseline of, hey, look, you're going to feel this for 1 to 5 seconds, and you need to just leave your hand up the entire time. Give us some coaching so that they can know what's going on. I know it takes time. But you should be able to do this in a couple minutes and determine, hey, look, we've got a problem here, you know, and this is definitely the tooth. And I tell you what, too, is when you're billing out for your limited oral exam, then you feel better about it. You know, like, hey, look, we did our due diligence. The patient wants to pay. You've created value. And you feel better about going in and doing the root canal.
And one little tidbit that I learned from Charles Blair is that there is an insurance code for pulp vitality tests, which you can submit if you do it, and it sometimes is reimbursed. So that's something that does get you paid for doing that sometimes. It's at least worth trying. And I think that the biggest thing that I've seen, again, as far as pitfalls is misdiagnosis of endo because it's really occlusal trauma. And occlusal trauma can feel every bit like a toothache, and it can be thermal sensitive. And endo ice is almost the gold standard there, because if you test that tooth with endo ice and it's reversible pulpitis, then you're stupid to go in there and do a root canal. You know, you need to maybe think about occlusal adjustment or a splint or something. But there's a lot of root canals that get done because of that, and then we end up with more problems.
I think even more now that we understand more about muscles and joints and how to get teeth, more comfortable, we probably are saving patients some root canals.
Definitely. So, I know that's changed the way I look at it.
Right. So, I mean, definitely when you go in and clinically look at these things, are you using a tooth sleuth? Are you using endo ice or some type of diagnostic cold or heat test? Are you doing some type of percussion test? And I think these things are important. Do you probe? The periodontal probe detects so many things other than periodontal pockets. It detects root fractures, and it detects bone loss and real problems that can save yourself some diagnostic time before diving in and doing a root canal that you might just need an extraction. If you're probing like in one particular area, and don't just pick 3 points on a tooth or 6 points on a tooth. Literally go, I'm talking literally go millimeter by millimeter around the tooth that you feel like you've got the problem, and really try to find some type of pocket. And a lot of times it'll fool you because you'll be 1, 2s, and 3s all the way around the tooth, and you get like distolingual somewhere, and it just drops to 15. And you're like, whoa, holy smokes. And the patient goes, yeah, that's it. That's where it's at. And you just pull the probe out, and here comes the pus.
Right.
And the patient's like, yeah, that's the whole area right there. That's really sore right in that area. That's where I've been feeling that pain.
Sure.
And
probing is huge. It definitely
it's huge.
You definitely can't forget it. You don't want to miss something. And again, go in there and then you open the tooth up and it turns out it's
definitely
fractured.
Be screening your patients for chronic sinusitis. I feel like these patients in the spring and in the fall, they really struggle. John and I live in an area where we have really one of the highest pollen counts in the United States. There's probably, I hate to say this, there's probably more root canals done here than there needs to be. I know myself, I've backed out of it and treated people for sinus infections, and pain goes away because I can't elicit enough positives in the do the root canal side to be able to perform the procedure. So,
and I think when it's all said and done too, the clinical tests, there are days where you just have to bring the patient back. I've had those days where you go through all the tests, and maybe, assuming that there's no radiographic findings, you may have to bring the patient back and retest and tell them that you're not sure, or refer the patient, and that's okay to do. If there's anything you learn from the AAE matrix here on diagnosis, it's that there's a lot of things that can be going on, and if you're not sure, that's all right, and do the right thing and refer the patient if necessary, or bring them back. That's what I would want if it was my tooth, for sure.
That's for sure. So John, we're taking we've narrowed it down to a particular tooth that we feel like has a problem. The next step, I guess, is just traditional intraoral radiographs, right?
Right, for sure. Yeah, and that's your next step, and you start with a periapical radiograph. I think that's pretty universal. You might want a bite wing as well if you suspect that there could be a problem involving decay. It's often hard to see the extent of decay on a periapical, so you may take two. You may take a shift, a type of periapical as well, if you don't know for sure that you can see all the roots.
How about the old slob rule, John?
Well, you can use that. I think with CT, I think that sort of has gone away in my practice.
Seriously, guys. How hard was it in dental school to think about this slob rule? Take a flashlight and rock it around to the me's and look at how the projection on the wall changes.
Just imagine how this projects.
Just imagine how this projects.
Now turn it around in your mind. Right. Yeah.
Come on, guys.
And we're going to get into that later in the show about CT imaging. So we'll just kind of leave it at, I think, next step is radiographic. And if you pull up the AE diagnosis matrix, you're going to see that, there are clear indications of when you have a chronic apical abscess versus an acute apical abscess, and what that truly means, and how to evaluate loss of the cortication of the PDL, the widening of the PDL space. These are things that we all learned in school. And it's sometimes you need to, again, I differentiate between, is this occlusal trauma? Is this true widening of the PDL? Those are things that, you should be correlating your thermal test with your radiographic findings and coming up with a diagnosis that matches one of the things on that matrix sheet and make sure that you're where you need to be. So let's assume that we've gotten through that. And that's a very cursory, if you want to take a really great course on these, on diagnosis, go to one of the great endo courses that are out there. There's so many of them. Go to one of the major ones, and there's courses that spend a whole morning on diagnosis and differential, but that gives us at least a starting point, assuming that we've determined, Wes, that we need to do endodontic therapy. Okay, so we've determined this tooth has irreversible pulpitis or necrosis, pulp necrosis, and we know we need to initiate endodontic therapy. We're going to base kind of the next phase of this discussion today on right out of the AAE's, what they call the 3D approach to treating acute pain, because this patient is in pain sometimes, and sometimes they're not, but sometimes they are. And the question is, how do we manage the acute pain in the office? Because sometimes we can treat the patient right then, but that's pretty rare. In my office, I can't a lot of times just stop and do a root canal right that moment.
You got an hour and a half opening, man. Come on, all the time, right?
Right, all the time. Yeah, every day.
All the time, every day.
So if you got to bring the patient back another day to do it, then how do you determine how you're going to treat the acute pain? And I think the first step in that is we've already talked about. Establish a correct, proper diagnosis. Make sure you know what's going on, because your treatment of the pain obviously is different if you have a clear buccal vestibular swelling with pus versus an irreversible pulpitis that is asymptomatic, or slightly symptomatic, or is extremely symptomatic, or a necrosis situation or trauma. You're going to treat those all very differently. So, Wes, why don't you go through some of the things that you do that are dental treatment? Because the 3D essentially is, number one is diagnosis, number two is dental treatment, number three is drugs. We'll get to drugs at the end. What are some of the things you might do in your practice for some of these different diagnoses that wouldn't be definitive treatment, but would relieve some of the pain that the patient is in?
Well, the first thing I do is I offer if you got a patient sometimes sitting in a chair, they can't even talk to you. They're hurting so bad, they can't even talk to you. So you know what? Numb them up.
Yeah, little Marcaine.
Little Marcaine. Holy smokes, man. You talk about demeanor change.
Yeah, make their day right there.
Oh, you'll make their day, and you'll make their evening, because they're going to be numb for a long time.
Yeah.
And so I feel like they might not completely be out of pain, but at least they're going to have a lot of relief. How many patients do you have trouble even talking to?
Yeah, you can't even have a discussion because they're just holding the side of their head.
They're like this. I'm like, Doctor, I can't even talk to you right now. I don't know. There was this one, like a year or so ago, I had this guy. He would never commit to comprehensive dental care, and he would always come in, and he knew he would come in and his eye would be swollen. His face would be swollen, and I would always just say, he was like, "You want to be numb?" He was like, "Yeah, please just numb me up." So I would numb him up, and then we would talk, and I'm like, "You want to take the tooth out?" And he would always say, "Yeah, let's just take the tooth out," because he couldn't, and it was fine. He couldn't afford to do
those
root canals. You get those patients, and I would always just numb him up, and he was like, "Hey, dude," he was like, "Thank you so much." He was like, "I'm feeling so much better. Let's figure out what we need to do here." So first thing is like, "Hey, look, I offer that patient anesthesia. It doesn't take very long. You can actually talk to them better. If I see a fluctuant swelling, if I see a fluctuant swelling, I'm going to IND that thing.
Yeah.
I'm going to numb that patient up. And an IND, guys, it's like the easiest thing you can do.
And again, it is a practice builder.
It's so people just love you because what you've just did, they immediately, when you incise the fluctuants and the pus comes out of their flowing, you watch their face. It goes, oh. Yeah. I mean, literally, if you've never had a dental abscess, I've never had a dental abscess. John, have you ever had a dental abscess?
No.
But I'm telling you right now, I've done a lot of INDs. I did a residency in a hospital. We've done through the neck, or the whole bunch. But you're not going to do it through the neck in your dental office. You might if you've had training, but in the mouth, you should be able to do an IND. And if you don't know how to do an IND in the mouth, you need to go get some training on this, because you can change people's lives.
Right.
I mean,
and you shouldn't be. And really, I would say that if you are currently prescribing antibiotics when there's a fluctuant swelling,
bring it.
Yeah. And that you need to stop that right now.
Right now.
I mean, tomorrow.
Tell me why, John.
Well, first of all, it doesn't really work because it takes how long for these things to get to a plasma concentration that's reasonable? 24 to 48 hours, depending on the meds. If you're going to do that, at least do IV antibiotics.
It's pretty ridiculous.
And if you don't have an IV
and you're not INDing, come on.
Right. I know. I mean, but it's like, we see this how many times? I mean, all the time people are like, well, they come in 24 hours later because some other office gave them antibiotics for their fluctuant swelling. And you better hope that patient doesn't die or end up in the ER with Ludwig's angina because you didn't IND them when you could have. Or you better hope that they don't have a reaction to antibiotics and have a problem, because that is the wrong treatment for their...
I cannot wait till we get to our pharmacology episode.
It's going to be
Please
a great
hold
one.
me down right now, because I'm just getting ready to release on you
want to rip
guys.
face, don't you?
I'm going to rip face
because
we are bad. We are bad at prescribing, over-prescribing.
Well, let's just say, though, hold on, because I know you want to go there. I know Wes, and we're going to get there. Wes is going to rant like he's never ranted before in that episode. But let's just say, guys, stop it tomorrow. INDs and some type of limited treatment is what's indicated for infected teeth that are symptomatic. If you don't have time, and I would say you always have time to do an IND.
Okay,
you always have time.
What about?
But if you don't have time to do a pulpotomy, or you don't have time to do...
Just reduce the occlusion.
Right, exactly. That's what I was going to say. What about just reducing occlusion? Yep.
Oh my goodness, you're going to do a crown on it anyway.
Right.
Oh, but doctor, it's going to change their occlusion. You're going to rebuild it.
Exactly.
And when the swelling goes down, it'll be cut back for you 0.5 millimeter. So
That's right.
there.
That's right.
I mean, like the other day, case in point, this guy walks in. He's like, why is it that I can't close my mouth? He was like, this tooth is killing me. We knew we needed to we took an x-ray, obviously. And then we took a CT because we knew we were going to do, and we'll get into the CT thing. But the whole sinus was like just obvious above this tooth. It was just like this big giant bleh.
Yeah.
You know? It's like bleh. Just this pus coming up into his sinus. The tooth had hyper-erupted 0.5 millimeter. Guess what I did? Got a burr out and reduced the occlusion. You're like, well, I got to numb him up. No, you don't. No, you don't.
No.
Because most of those cases, they're necrotic.
Yep.
You turn that high water on and you just lightly brush that tooth and reduce that occlusion. They're like, oh, I can touch my teeth together. Doctor, this is amazing. You've made me feel so much better. You're a miracle worker.
That's right. And I think, again, the next step from
Sorry,
there
I'm ranting
is...
a little bit.
No, it's good. It's good, man. I mean, because you gotta realize that these little simple things make a difference. Now, there are cases where you have now, here's the hardest one. The hardest one is the symptomatic, irreversible pulpitis. This is a tough one because the patient comes in, they're in pain. They don't have a swelling, they don't have infection, they just have irreversible pulpitis, and they are just dying. They're dying.
Gas, man.
Yeah, they're hurting. They're sensitive to everything that touches the tooth. They're sensitive to all temperature with extreme lingering sensitivity.
These are tough cases.
And
these
those
are the cases that give root canals a bad name.
That's right. So you have, in my opinion, you have two choices there. And there may be people that disagree with this, but I think you have two choices. One is you manage them with drugs.
Yep.
And that's a choice. The second is you do probably the best thing, the better thing, is to open the tooth up and do a pulpectomy, or at least a pulpotomy, and try to actually address the dental problem rather than
that's going to be a
mask it.
touch and go procedure. I'm going to be just straightforward honest with you. You're going to be doing a lot of ligament injections around the tooth to try to get this patient numb. You're going to do a lot of intrapulpal anesthesia. We'll get into that maybe in another episode, but
it sucks.
But it's going to suck.
Yeah.
Let me just tell you, that patient's going to love you when it's finished.
Right.
They're going to feel so much better.
And they're not going to ever want to have it again. So hopefully you convert that patient into somebody who you say, listen, I know that was no fun. There's no easy way to do this, but let's make sure that you stay dentally healthy so you never, because a patient that has that symptomatic irreversible pulpitis tooth, man, they never want that again.
Yeah, before you even start a procedure on a hot tooth like that, go ahead and give them some NSAIDs.
Yep.
Go ahead, doctors, please, in your offices, have the 800 milligram big old horse pill that you can just say, hey, go ahead and take this.
Right.
We know we're going to go ahead and open your tooth up, because that's been shown to increase the effectiveness of local anesthetics.
Absolutely. Local, that plus nitrous is a great preoperative combo for these patients. And we're going to get more in anesthesia. Don't worry. We're going there, guys. But I think that that's exactly right, Wes. You know, you're going to have a hard time, but those cases, either manage them with drugs, do the pulpectomy, pulpotomy, or refer. These are just some situations where you may have a patient
and you just can't deal with it.
You just are like, I can't do anything about this right now, and you know that pain level's not enough, or it's not low enough where you can prescribe and feel comfortable. You know, you just need to stop sending those patients home with narcotics and drugging them up like crazy and say, you know what, I'm going to send this to my endodontist, because endodontist, a good endodontist, I think a part of their practice and why they get paid the big bucks is to handle those types of patients. My endodontist, who I work with all the time, a great credit to her, she's told me before, you know, if you ever have a patient that's in pain and they just need to get out of pain, I will make room for them. So she will see any patient at any time if they're in that situation for me, because she knows, number one, that's a great practice builder for her. Yep. And number two, the patient is going to get out of pain. And plus, she knows she's going to get paid. It's a good situation for everybody because the patient's motivated, she's motivated, and that has produced a lot more for me over the years of me saying, you know, I'd love to do the endo, I just can't. I need to send this patient to the endodontist and just let her do a pulpectomy that day. The patient goes home out of pain, and I'm not giving them needless antibiotics, needless pain medication. But if you can manage the pain medication, if you can manage it with pain medication, that gets right into the drug part of it. I think there are times you can. So Wes, what are the pain medications that you give in that situation? Say you have a patient that's not at the point, not at the breaking point. They've either got a necrotic tooth with an abscess that's not draining, it's, you know, radiographic and there's percussion sensitivity, or a patient with irreversible pulpitis, but it's not hugely symptomatic. They're hurting. Maybe they're a 4 to 5 out of 10 on the pain scale. What's your protocol for pain
First thing
control?
I do is I reduce the occlusion. And then the second thing I do is I prescribe typically a Medrol dose pack. And really at this point in time, like, there's no swelling. We're dealing with more inflammation than we are even, you know, just think about this, guys. Okay, patient has an MOD on a tooth. Yeah. Okay. And then the next visit, you know, down 5 years, 6 years down the road, 10 years down the road, they have a crown done on the tooth. Okay. Just because the buccal wall fractured or something like that, the cusp broke off. So they had a crown. You look on the radiograph and you're like, dude, there's nothing wrong with this tooth. There's no decay or anything. And you're trying to explain to the patient why they got a root canal, why they needed a root canal. The reason why is because the pulpal tissue necrosed and it released gas. You know, when stuff dies, have you ever smelled roadkill?
There you go.
That's the title of the show, man. Have you ever smelled roadkill? It releases gas, and the gas inside their tooth is going to cause inflammation.
Right, okay? And you've got the cytokine release. You got this.
So, John, why would you prescribe antibiotics for that?
Right.
That's my point here. Is like there's
we know that antibiotics are not going to make a difference, and I would refer everybody to this. You know, a 3D approach for treating acute pain. It clearly goes through whether or not there is any reason for antibiotics, and the answer is unless they have a fever, and malaise and night sweats, and or it's a life-threatening infection. Really, if it's life-threatening, you need to be on IV antibiotics.
Yeah, let me
There's
tell you
really
right now.
almost no place in the practice for oral antibiotics in the treatment of these patients.
Yeah, I agree. The thing is that we're overprescribing. We need to be using Advil Motrin. We need to be using some type of naproxen.
And that's what I prescribe. Like when these patients come in with this acute pain, you know, I typically, not that Medrol is bad, it's great.
Well, the thing about Medrol, let me explain the pharmacology there
Well,
about
I prescribe Tylenol and Advil as a mix, that or Tramadol, and
that's the thing,
those. That's a great combo.
the Medrol is not going to kick in for about 48 to 72 hours. Now, if you have the ability to throw in one intramusculature or throw it in IV, then fine. Go ahead and throw that in. You're going to get immediate results from that. But to get it up in the blood, it's going to be a couple days. So Medrol might not be the first choice. So what's the first choice? It's Advil. And prescribe the 800s, guys. Prescribe the 800s because the patient's going to be more compliant. They're going to get it up in their system, and they're going to get it going. And then here's what you tell them. What about the over-the-counter Miracle, John? The over-the-counter Miracle is a combination of 800 milligrams of Advil and an extra-strength Tylenol. That's 1,000 milligrams of acetaminophen. To be honest with you, you can give less than 800.
Yeah, I typically give 400
you can do the
ibuprofen
400,
and 1,000 of acetaminophen.
The two combined together has a synergistic effect, meaning they play off of each other, producing a highly significant analgesic effect. It has been shown to be equivalent to that of Percocet.
Yeah.
So the thing is that there's no reason to prescribe narcotics. The Norcos 5/325s, the Lortabs, the Vicodins, all those things, Vicoprofen, those are not necessary in dentistry. Stop prescribing those medicines because there is no good sign for it unless we have a special situation.
Right.
And those special situations call for special times.
Right. And we're going to cover that even more in depth when we get to a pharmacology discussion and on a show. But it's a very good, I think, reminder of just saying, treat the dental problem first, then treat with appropriate drugs. Avoid narcotics, avoid antibiotics unless there are specific reasons for those things to be given. And let's talk now about really one of the biggest things that have changed in the way we over the last couple of years have done endodontics, which is cone beam CT. And how has that changed things, Wes?
I'm laughing right now because, John, I couldn't do it to you, man. This weekend I'm studying for this thing and I'm studying for this podcast. Yes, I study for podcasts.
Yeah, we do, man. That's good.
And you and I had a disagreement up until just Saturday morning, and it was the disagreement that, hey, I was just automatically, for no reason, just other than the fact that I wanted to be more confident about my diagnosis, that you can ask some people, ask Chris and Jeremy, all right? Because they both shadowed in our office and they were like, well, Wes takes CTs whenever he's going to do endo prior to doing endo to rule out whatever. And John doesn't. And John and I just had this disagreement about it. And we thought that, hey, look, on the show, we're going to argue about which one's right over another. So I just got on AA's website and they have this whole consensus.
Yeah.
On
and there's a new consensus
CTs.
statement that's out that was just updated literally like a few months ago. About when should cone beam CT be used in endodontics.
I just couldn't do it to my boy, man. I just couldn't, even though it'd be
Wes
fun,
sends it over, and I was like, well, there we go. Because what I always felt like was that the question always is it actually proven to increase your ability to properly diagnose? I have no argument that it assists you with treatment, and I never had that argument. I think there's some great, but the question was, did we need it, or was it just something we were doing because it made us feel better? Was it actually going to make our treatment better? And I think this consensus statement kind of just puts that to rest. It says basically that in the posterior part of the mouth, premolars and molars, that CBCT is the imaging modality of choice for pre-operative radiography. So that means that, take a PA. That's great. That's a good start because it helps you to kind of zone in on where you're going. But you should be taking a CT before you do premolar or molar endodontics as the ideal. Now for anteriors, when there's no problem, when you're not worried about anatomy, it's not necessary. But if you have a question about anatomy or if you have a question about diagnosis. And those were the times I was doing it, was when I had a question about anatomy or when I had a question about diagnosis. But I wasn't doing it routinely for molars.
Right.
I wasn't doing it routinely for premolars. And after reading that and looking at the studies, it's there.
Yeah, let's just rattle off some statistics for you guys. Well, first of all, the question I asked John months ago was like, hey, look, dude, can you honestly say that taking a radiograph. Well, just let me get into it, because the thing is that you need to start taking them. All right, and it's just another reason to have access to a cone beam. Is okay. Primary endodontic lesion detection with traditional intraoral radiographs, 20% compared to 48% detection. Okay, the resolution is there to detect lesions primarily. CBCT detected 17% more teeth with periapical bone loss than that of conventional radiographs. Studies show that there is a strong correlation between sectioning teeth and CBCT canal detections, meaning like if we took a tooth and we cut it in half looking for 4 canals, 5 canals, that there is a strong correlation between actually physically looking at the histology of the tooth and taking the clinical radiograph. MB2 detection is higher with CBCT than conventional. Higher detection of vertical root fractures. 88% sensitive, 75% specificity. Now, I looked up the difference because I had to go back and look at these little words, and they mean a lot. Okay? Whenever we're talking about medical diagnosis, the word test sensitivity means the ability to correctly identify those with disease. That's a true positive. Like, we don't want false positives, we want true positives. So CBCT, true positive vertical root fractures, 88% of the ability to truly give you a positive where there's a vertical root fracture there.
9 out of 10 times you're going to see it.
Right. So then it says, what about specific? How you say it, John?
Specificity.
Yeah, specificity.
I love it.
Oh, man.
The S word.
So anyway, that S word. Yeah. So is the ability of the test to correctly identify those without disease. 3/4 of the time, you're going to be able to say, that's a normal tooth, that's a normal tooth, that's a normal tooth. And then 88% of the time, you're going to be able to say, there's a vertical root fracture, there's a vertical root fracture, and to definitely determine. We could go on and on here.
Yeah.
You definitely need to be taken for retreats. What about that, John? Every single time.
Every single time.
I mean, we could just keep going on and on. You can go look it up for yourself.
Yeah, I think that what I got from this is that, first of all, immediately it says that, if you don't have a CT machine, it gets a little crazy there. Like, should you be doing molars? And I'm not saying you can't do good molars with it, because
and they're not saying that.
They're not saying that. They're just saying it's the imaging of choice. They're saying that it's the best case scenario. You get the most information out of it, and it gives you more than what you get. And I definitely agree with that. But now we're seeing that it's so much better that it really is something that you may want to consider as a reason, once again, to look at CBCT in your practice if you really want to do endo at the highest level. I just saw a case just last week where I had a young girl, 3 root canals done, 3 missed canals on her teeth, and she came to me with pain on one of them, and she's had now crowns done on these teeth, and all 3 of these teeth are going to need to be retreated just because. And I took a CT. It's clear as day. Clear as day. I mean, these weren't difficult to find. And if you know what you're getting into, it just creates a whole different mindset when you enter a tooth and there's 4 canals and basically where they are. And if you don't find that 4th canal, you're not going to finish the case. And it just changes the way you look at it. So it's something to definitely think about. And we probably should just finish up this episode talking a little bit about cracked tooth diagnosis and prognosis. I think it's probably one of the last keys that we talk about many times. When a case comes in, you suspect a fracture, you have a tooth sleuth positive result on a cusp, and the question is, I've wanted to know until all these studies came out, well, what's the prognosis for that tooth?
Yeah, this is what is good, guys. I want you to pay attention to this. It's so important. I
think that, and this goes back a while. This Endodontics Colleagues for Excellence was something that came out back in 2008. And I would check it out. It's called Cracking the Cracked Tooth Code. And there's more studies that have come out since this time. So this isn't the be-all and end-all, since this is almost 10 years old now. But even 10 years ago, when they looked at studies of what the long-term prognosis was of endodontics with cracked tooth diagnosis, confirmed cracked tooth diagnosis, roughly 10 to 15% worse endodontic prognosis with fractures. So that's important. That's something you can take to the bank, and you can tell a patient, and you should be telling patients when they have a diagnosis of a cracked tooth, that first of all, there is a decreased prognosis of success. If you're not telling them that at the beginning, you're going to start telling them that. I guarantee you, once you start seeing failures, it changes what you think about. The second thing that they bring up is that when they looked at the long term on some of these cases, and they said, okay, if we have a reversible pulpitis diagnosis, pulpitis, and there's a fracture, and you put a crown on the tooth, a crown alone, no root canal treatment,
what's the success rate?
Is the percentage of those patients who end up needing endo? 20% of those cases within 6 months. Yes. So
within how many months, John?
6 months. 6 months. So you need to definitely be very aware that just because you have a reversible pulpitis diagnosis on a cracked tooth, you don't tell that patient, well, we'll put a crown on this and it's fixed. You tell the patient, we're going to put a crown on this, and you can feel confident saying in roughly 20%, these teeth still need root canal. So just be aware that we may make you the best crown ever, and it may feel great for 1 month, 2 months, 3 months, 4, 5, 6 months, but it still could need a root canal. And the other thing was that none of the other teeth, 80%, required root canals over a 6-year evaluation period. So you can also feel good that if you get through that 6 months, you're probably not going to need a root canal.
So John, this is the thing. And I was teaching in a class this past weekend, and I was teaching the difference between a mechanic and a doctor. And a mechanic can do a crown prep. A mechanic can do a root canal. A mechanic can do a filling. It is a mechanical thing that we do. It involves hand skills and a systematic approach to doing the procedure. But what makes a doctor is somebody that has the ability to set that patient up and say, look, we put a crown on this tooth today. The prognosis of this tooth, based on what I'm seeing, is fair to good or good to excellent. However, in some cases, you may end up having to have a root canal, and they're going to raise their eyebrows. And no matter whether you're crowning the tooth for some reason, right? Because there was some failure of restoration, decay or fracture or large filling that had micro cracks coming out from it. It's already a compromised situation, I tell my patients. But what we know is that there's a lot of good tooth structure left here, but there's still a chance, even in the best case scenarios, that you might need a root canal. And the good thing is that we're going to give you a few weeks, or we're going to give you a few weeks in a temporary, or we're going to actually put the crown on today. You've not been having symptoms in your temporary, and that's good. That bodes well. And the crown is designed with technology of today that we can actually re-enter through the top of that crown and not cause harm to the crown in most cases. Yeah. So I offer sometimes a guarded prognosis. So the difference between a mechanic and a doctor is that a doctor applies biological thinking and prognostic indicators to give that patient a prognosis of the outcome. Right. You see, if you go to the heart doctor, and here's where we mess up in dentistry. We become so mechanically driven because we are widget-oriented, mechanical. We sit down with a drill and a handpiece and a file, and we do a procedure over and over again that we really forget that we're dealing with biology and the human variable. And the difference between us and a cardiologist sometimes is that we forget that that cardiologist is a mechanic as well, except he's a plumber. That cardiothoracic surgeon that did heart surgery on your grandma or your papa or your dad is a plumber, and he can stitch vessels in and bypass arteries and all day long. But what he truly does is he sets that patient up at the end of the day and says, look, prognosis-wise, we feel like it's good if these things happen, or if these things don't happen, this could be the prognosis. Right. And why are we getting away from that when we're treating root canals? Why are we getting away from that when we tell patients, when we set them up? Because we get busy and we forget and we become mechanical. And that's
I completely agree. And I think that's what this show hopefully has done for you, is it's brought us back to, we haven't even talked about the procedure yet. And we do that on purpose because if you don't get this, if this episode was like boring to you, then you got to listen to it like 27 more times, because this is it, man. This is it. Like, I don't care if you fast forwarded.
This is why John and I do so many implants, is because we diagnose.
Yeah. If you're like, oh, I would just get to the clinical. Well, the only way you're going to get to the clinical again and again and again, to where patients actually want to come back and get another root canal because it freaking worked, is because you understood why you did it. You treated the right tooth. You treated the right spot on the right tooth. You found all the canals. You did proper diagnosis, and that is why you had success. Yeah, the mechanical side of it we're going to cover in the next episode. We're going to go through from start to finish.
But to me,
this is really it. This is what separates, as you said, Wes, the mechanics from the doctors. This is why, if you apply these principles, you will eventually become someone in your community that does excellent endo. Because if you ask the endodontists in your area about a lot of the problems, they'll tell you it's diagnosis related. They'll tell you that patients are coming in with the wrong diagnosis and poor imaging quality, and cases were done that should have been done by the specialist, or they should never have been done at all. That's what they're seeing, I think, more problems with than they are the actual mechanical issues. It's just not knowing what they don't know. So commit yourself to figuring this stuff out. Next episode, we're going to go into the actual mechanics of it, and how do you do a root canal from start to finish?
Excited about
how do we
that
do a root canal?
Because there's a lot of like stuff out there that people want to buy. You know, to help think they're going to make, we're going to dive and cut through
stuff.
all that.
Yeah.
There's a lot of stuff out there on irrigants and file choices, and whether we need to be using NiTi and stainless steel, or, hey, what about rotary endo? Like, do we really need auto reversing, hand pieces, and those type things? I mean, like, there's so many things that are sold to us that
a lot of products
matter not.
Sure. And we're going to talk about, what matters and what doesn't, and go through from start to finish doing root canals with patients. And I think you'll be able to take a lot of that and directly apply it. And just be aware, we're not going to be going in and saying there's only one way to do it. And so if you're thinking we're going to just give you exactly what you need to do, you're going to find Wes and I use different rotary systems.
Yeah.
We use different ways of doing things, and they both get us to the same basic point, and we were taught by the same people. So, that if that doesn't tell you something, then, you start to realize that, again, it's about the biology, and it's about the diagnosis and the biology. And if you get those things right in dentistry, you're usually going to have good outcomes regardless of the products that you use. And that's, if there's one thing this show hopefully is teaching you, is that it's that products matter sometimes a lot, but rarely they really matter. And it's more about what you do and what you know. And that's why you come to this show, is because you want to take it to the next level. You want to go beyond just buying products and asking, well, what are you using? What are you using? Why is your stuff working? My stuff's not working. I feel like I need another product. No, what you need is, you need to understand better, and you need to have it, and we do too. That's why we're going to Spear to this next level course on sleep, because we don't understand as well as we need the true basic science. We're right in the same boat as everyone is. So we want you guys, if you've enjoyed this discussion, we want you to let us know. We also want you to let us know if there are things that we can talk more about when it comes to endodontics. What is it that you're struggling with? What are your successes? We want you to let us know. And Wes, too, there's a lot of ways they can connect with us on social media, too.
Yeah, I feel like that one of the things that we love to do is we love to tweet and we love to Facebook, and that's a great way to get in touch with us. One thing you should know is that we do have a YouTube channel, and you can watch us talk and listen to the show there, and sometimes we'll throw up clinical pictures of cases and things like that, but it's another way to touch with us, and we really feel like that the social media aspect of things has really helped to take this show to the next level. But what we need you to do today, right now, if you're listening to this show, is we need you to go to iTunes and we need you to give us a good rating. We want you to give us 5 stars because we think the Dental Guys is bringing you quality content. And so if you'll go to iTunes, if you'll go to our Facebook page and give us a like there, follow us on Twitter, give us a shout out, and we're really good about responding to messages. And so if you've got a question or something, we try to respond with those in a timely manner. But this has been a great episode, John, and
sure.
I've learned a lot because what I do every time I go back into looking at these things is that I'm forced to reread some of the things that we learned in school and we learned along the way from some of our great mentors like Dr. Ruddle and Dr. Buchanan. And I want to give a shout out to those people because they truly changed my perception of endodontics.
Yeah,
and
for sure.
I know they did for John as well and for John's dad as well. So this has been a great show, and for us here at the Dental Guys, we want you to take it to the next level, and we're looking forward to more episodes just like this. Tune in next time where we discuss more about how to get from point A to point B with your root canals and cut through all these materials. So again, for Wes, John, we are the Dental Guys.